Good evening, everyone. On behalf of Dr. Agarwal's Institute of Optometry, I take this opportunity to welcome you all for the sixth episode of Optometry series. Thanks for giving a continued support to us. The topic for today is non-strabismic binocular vision disorders, basic evaluation. I'm very happy to welcome Ms. Maheshwari ma'am, HOD of Research and Innovation. Hi, ma'am.
Thank you.
Ma'am, we
So,
missed you in the last session, ma'am. You are not there.
thank you. So, yeah, I was not able to join the last session because I was having a meeting which was at the same time. So, I would like to thank Nivedha for accepting this talk and accepting to join today with us. So, I know her, for the past 4 or 5 years, and I've heard about her, the way that she sees her patients. She's a very good clinician. She takes good clinical decisions, and the binocular vision as such, we think that it's not it's not an easy topic that you do one course and you can handle binocular vision cases. It requires a lot of application of other skills and take a proper clinical decision. And we have we all know that COVID, so she's cleared that exam, fellowship in COVID. So we can, I don't know whether I'm correct. There are only 4 FCVODs in India. Am I correct? 4 or
Yes.
Yes,
Yes,
okay.
ma'am.
There are only 4 people in India. So she is one among the 4 people in India. So, she is, she's got that expertise. So we are very happy to have her here and share her expertise. And thanks for your time, Nivedha. So, and I would like to, formally call Teja, who's going to invite our guest. Yeah, over to Teja.
Thank you, madam. Thank you for the introduction.
Thank you, ma'am. Good evening to everyone. Before we proceed, I would like to introduce myself. I'm Teja, doing my second year in Dr. Agarwal's Institute of Optometry, Chennai. And today we have a lovely speaker, Ms. Nivedha Sanjanam, B. Optum, FCVOD. She's an associate member of COVD, College of Optometrists in Vision and Development in USA, and associate member of Australian College of Syntonics. She's also a member of Indian Academy of Cerebral Palsy. She worked as a consultant optometrist at Sahaji ICAT, Nagpur. Currently, she owns a vision therapy clinic in Kids Care Pediatric Neurology Center, Raipur, since 2015 till date. Also, she has 13 years of experience in special children and vision therapy. Presently, she is pursuing a master in clinical optometry from City University, Britannia, and completed Syntonic 101 course from Australian College of Syntonics. We are glad to welcome you, ma'am. And today we have our speaker, Ms. Rafathunnissa. She completed her B. Optum in Dr. Agarwal's Institute of Optometry and doing internship in Dr. Agarwal's Eye Hospital. Over to you, speaker, Rafathunnissa.
Thank you, Teja, for the introduction, and all the best to Rafathunnissa for the presentation.
Thank you, ma'am. Just a minute, I will share the screen. Today, I'm going to present about non-strabismic binocular vision anomalies. Introduction. Non-strabismic binocular vision and dysfunctions are visual disorders that affect the binocular vision and visual performance, especially when performing tasks requiring near vision. They occur when the accommodative or Vergen's response of the visual system is defective. As a result, the visual system may suffer a loss of efficiency, hindering near vision activities. NSBVA were found to be more common among school children between 9 and 13 years. Undiagnosed binocular vision and oculomotor dysfunctions may present with discomfort, which can have a negative impact on academic performance. This one. Does squint been associated with NSBVA?
So you can, students can, put your answers in chat box.
Yeah, ma'am. So quiz part will have slight interactive sessions. So in between we'll have 3 quizzes and we'll see one case example. Quiz number 1, students can answer in live chat in the YouTube or Zoom. Continue, Rafat.
Okay, ma'am. Prevalence. Accommodative and non-strabismic anomalies of binocular vision are reported to be highly prevalent among school children, with estimate of close to 30% according to a recent population study-based study, which was conducted on 2016. According to this study, the prevalence of NSBVA was estimated to be 31.5 and 29.6% in the rural and urban population, and convergent insufficiency has been reported to be the most common and non-strabismic anomaly of binocular vision. Best vision. The efficiency of the visual system is beyond 20 by 20. Many eye care practitioners unfortunately still assume that 20 by 20 visual acuity ensures an optimally functioning visual system. The efficiency of the visual system is not just dependent on the integrity of the visual apparatus and monocular visual acuities, but also on a well-functioning and integrated binocular vision. So when a patient complains of stenotic symptoms unexplained by a regular eye examination, a comprehensive binocular vision assessment is warranted even in the absence of significant refractive errors. VV problems. Symptoms associated with the use of the eye: visual acuity is normal, eye health is normal, binocular vision problems. Steps in assessing the NSBVDs. Measurement of fovea with cover test, AC by A ratio with wonder of fovea, modified Torrington, fixation disparity. Then assessment of NFE and PFE. Direct measures includes smooth version testing, step versions, and versions facility testing. Indirect measures includes negative relative accommodation, PR, positive relative accommodation, fused cross cylinder, binocular accommodative test, and MEM. Convergence amplitude sensory status, NPC, Worthforth dot, and stereopsis test. Assessment. Measurement of fovea. Cover test, an objective method of evaluating the presence, direction, and the magnitude of the fovea. AC by A ratio for diagnosing. For diagnosis, we majorly use calculated method. Direct measures of negative and positive fusional versions, smooth and step versions. It evaluates fusional versions amplitude, NFP and PFP methods are used. Versions facility, ability to make repetitively versions change over an extended period of time, measures the dynamic and fusional version system. Calculated AC by A ratio. To determine the change in convergence that occurs when the patient looks from distance to near. The calculated AC by A ratio is determined using the following formula. AC by A ratio is equals to IPD in centimeter plus NFD in meter M and HN minus HF. IPD is interpupillary distance in centimeter and NFD near fixation distance in meters and HN near fovea if it is in ESO in plus and EXO in minus, and HF far fovea ESO in plus and EXO in minus. Expected value, the expected calculated AC by A ratio is 6:1 with a standard deviation of plus or minus 2. Indirect measures of negative and positive fusional versions, NPA and NPC, to assess the accommodation and convergence amplitude. NRA, PRA measures the range of accommodation. Accommodative facility simultaneous accommodation changes in assessment. MEM, accommodation lead and lag is measured. Methods of assessing NPA.
So we would like to see the answers in the chat box.
Let's refer to continue.
Okay, ma'am. Sensory status, stereopsis, word for dot test to assess the functional and binocularity. These tests will be done. Normative data. The normative data for each test has been given in the above table with expected value and the standard deviations. Quiz screen. Normative range for stereopsis.
Kindly record the response in the chat box.
Yes, ma'am. Yes, Rafat, continue.
Okay, ma'am. Classification. Classification of NSBVA, heterophoria, accommodative anomalies, and oculomotor problems. Under heterophoria, low AC by A ratio, normal AC by A ratio, and high AC by A ratio. Under low AC by A ratio, convergent insufficiency, that is orthophoria at distance and exophoria at near. And divergent insufficiency, it will be esophoria at distance and orthophoria at near. For normal ACO by ratio, basic exophoria and esophoria. Under basic exophoria, it will be the same degree of exophoria at both distance and near. Under basic esophoria, it will be the same degree of esophoria for the both distance and near. For high AC by ratio, convergent excess and divergent excess. For convergent excess, it will be orthophoria at distance and esophoria at near. For divergent excess, it will be orthophoria at distance and esophoria at distance and orthophoria at near. Accommodative anomalies, accommodative insufficiency, accommodative excess, ill-sustained accommodation, and accommodative facility. Oculomotor problems, oculomotor dysfunctions have problems with fixation, succates, and pursuits. Exophoria is, if exophoria is present, investigate and analyze the NFE data, calculate AC by A ratio, and compare distance and near phoria. If the phoria at distance is greater than phoria at near, divergence insufficiency. Phoria at distance and is equal to the phoria at near, it is basic exophoria. Phoria at distance is less than phoria at near, convergence excess. Exophoria, if exophoria is present, investigate and analyze PFP data, evaluate AC by A ratio, and compare the distance and near phoria. If the phoria at the distance and near are is greater than the near, divergence excess. If the phoria at the distance is equal to phoria at near, basic exophoria. Phoria at distance is greater than less than phoria at near, convergence insufficiency. No phoria for distance and near, consider accommodative problem. Investigate and analyze accommodative data. Low value in all plus lens tests, accommodative excess. Low value in both plus and minus lens, accommodative infacility. Low value in all minus lens tests, accommodative insufficiency. No, if there is no phoria and accommodative findings normal, consider fusional vergence dysfunction. Low phoria, low base in and base out, low NRA PRA, low binocular BAF. The table above shows the condition shows fall or excess in certain evaluations. Thank you.
Rafat,
Yes,
sorry, ma'am, sorry to interrupt.
Yeah, please go on.
Can you
Please
explain about the conditions also? Just one line definition about what is convergence excess, what is convergence insufficiency from the table column or the flow chart?
Yes, ma'am. For divergent, if divergent insufficiency, patient will report exophoria at distance and orthophoria at near, ma'am. And in basic exophoria, both the distance and near, it will be the same amount of degree of deviation. In convergence excess, the orthophoria will, for distance, it will be orthophoric. When you're evaluating for the near, the patient will report esophoria, ma'am. And in divergent excess case, the patient may report esophoria at distance, while evaluating for near, the patient may report orthophoric. And in basic esophoria, for both the distance and near, the patient will have the same degree amount of deviations. For convergent insufficiency, at distance, the patient may report orthophoria, but near the patient may report exophoria.
Okay, Rafat, thank you.
Yes,
Thanks, Rafat.
thank you.
Now request the moderator, Ms. Nivedha ma'am, to kindly share some important points on the topic. Hi, ma'am.
Yes. Hi. Thank you, Rafathunnissa. So we'll just, I'll just a quick recap of our slides. So the very good topic is like basic evaluation of binocular vision problems, because we speak about the diagnosis, we speak about the management and everything. But the most underlying very basic cause or very basic evaluations where we tend to make mistakes can overall alter the values what we get in the evaluation and can confuse us with the diagnosis, you know. So that's why basic evaluation is really important. So if you see the basic evaluation, whether it's going to be a binocular vision problem specifically, a patient comes with you with certain complaints or certain symptoms. What I usually prefer, or you know, it can be adapted in any clinic, even when the patient is sitting in the waiting hall, you have a questionnaire called Quality of Life Questionnaire developed by COVD. I can even share it with the person who is organizing. She can share with the students and rest of the people. You have a quality of life questionnaire. Previously, it used to come with 30 questions. Now it comes with 19 questions. So in that, based on the symptoms, a person can rate. For example, if a headache is always present, he will put 4.4. If there is no headache at all, it will be 0. And all the points are added. And in the original one where 30 questions are there, if more than the value is more than 20, then it usually indicates there could be a binocular vision problem. So start with a questionnaire. When a patient is waiting, you can hand over the questionnaire. So that will give you a baseline that symptoms are leading towards binocular vision problems or not, or if it is something else. So that is the very first step. See, history and getting the points or getting the symptom list from the patient actually solves your problem. That's why in the medical fatality, people say that a good history taken actually gives you half of the diagnosis. So if good history is taken along with a questionnaire, which will tell you the symptom list, what are all the symptoms, how much is the symptom, you will easily come to know how you have to treat, how much you have to treat, and within what span you have to treat the patient. So that is the first point, COVD, Quality of Life Questionnaire. And then if you'll just remember the slides, she started saying that if you have BV problems, do a number of tests and all that. Before going into all that, first check for the refractive error. Rafathunnissa, can we go to your slides?
Yes, ma'am.
Yeah. Start from the first one, the introduction. She mentioned that binocular vision problems can manifest in many activities, especially for near vision. With my experience, when there is binocular vision problem, then a lot of your system gets disturbed. It's not only for the near vision, the peripheral vision, distance vision, the way the person walks in the environment, the way the person understands, the way the brain perceives, everything gets altered. So binocular vision is that important because the vision is actually the most dominant sense. If there is going to be any issue in that, then your overall development, if in case a child, and if it's an adult, then the overall work for the person or the activities of daily life can also get affected. Can we go to the next slide?
Yes.
Next one, next. Okay. prevalence is actually increasing. Even though studies have been done, there are symptoms, but if actually in a day-to-day clinical setup, if you evaluate 10 patients for binocular vision problems, I'm very sure you're going to detect problems in more than 5 at least. So even though the prevalence shows around 30%, but there are a lot of people, not only children, also adults, who have problems with their binocular vision, because most of them have uncorrected refractive error, or the refractive error is not corrected properly. So there is a disbalance in the accommodation system, which is obviously going to affect the virgin system too, right? So refractive error is the key. Go to the next slide. So in this, the visual acuity is normal, eye health is normal, it could be binocular vision problem. So in the clinical setup, see, I understand for every patient who walks into your clinic, doing a complete binocular vision evaluation obviously is going to take time. And obviously you might think that why should I put so much time, and only when any symptoms come and only when there are any issues, we refer the patient for a complete binocular vision evaluation. But in the clinical setup, how many of us do dynamic retinoscopy? That's a very, very good test, very important one. You can do it very quickly, and that will give you a lot of insights into the accommodative condition or the accommodative system of the patient. MEM retinoscopy, right? Monocular estimation method, where a near retinoscopy is done with accommodative target at 40 centimeter with the corrections on. Without the working distance, you see for lead or lag. You see what you try to neutralize the retinoscopy value there. And the usual values are somewhere between plus 0.5 to plus 0.75. If it is going to be more than plus 0.75, it clearly says that accommodation or the accommodation system is not effective. It could be accommodative insufficiency, or it could be ill-sustained accommodation, which is called lag of accommodation. And when it is lesser than plus 0.5, plus 0.25, plain O, minus 0.25, minus 0.5, it clearly says that there is lead of accommodation, which could directly indicate that there is accommodative excess. Also, that will tell you clearly that the patient's refractive error is not corrected properly. The patient is not wearing proper glasses at all, because for the 40 centimeter, if the patient is giving more accommodation than required, then definitely the accommodation is not relaxed for distance. And that clearly says that your retinoscopic values or refractive error correction is wrong. That is a baseline. See, just understand the whole binocular vision problem or everything is like a tree, or it's like a mountain or a pyramid. And the very base of it lies the refractive errors. So if it's like a foundation, just imagine, can you erect a building without a foundation? That's not possible, right? So if refractive error is not corrected properly, then how much of a treatment you're going to give, whether you're going to give AD, whether you're going to give vision therapy exercises, whatever, the problems may temporarily seems to reduce, but again, the problems are going to come back because you have not solved the base of the problem or the foundation of the building. So refractive error correction is very important. And when it comes to binocular vision, then there is something called binocular balance, which is very, very important. Okay, because see, even though we have two eyes, even though individually we have two foveae and individually images are reaching the brain, but the real view is actually binocular, right? So your both the eyes accommodative system has to be balanced so that vergence is very smooth, so that everything easily lies in the binocular vision range. So binocular balancing is very important. Binocular balancing, you have a lot of techniques. You can dissociate, you can use prisms, 3 prism base up in one eye, 3 prism base down in the other eye. So the patient is going to see 2 images. Okay. So this is done with the distance correction. You first do the monocular subjective refraction properly using the fogging method with the duochrome. Fogging method is used to control accommodation. And then you do binocular balancing. This is a very important aspect which we usually miss to do in many binocular vision clinics also. So start with a good refraction and then do binocular balancing use prism dissociation method or even alternate viewing method. There are a lot of methods, but prism dissociation method is a good one. Okay. And then check for the refraction. If required, do cycloplegic refraction. And if you feel cycloplegic refraction is not required, or if with regular fogging, you're not able to achieve required plus for the patient, you can do Borish delayed subjective refraction technique. That is, you use NRA value, the plus value, the maximum plus the patient exerts, and then you do your binocular balancing with that plus value. Okay. So binocular balancing is important. So till now, we thought what all we saw: COVD, quality of life questionnaire, and then a proper refraction, a regular MEM technique in a regular clinic. And after proper refraction, you do a good monocular subjective refraction technique, then going for binocular balancing. So half of your problem is solved over there. Then you go on to doing rest of the binocular vision test. Rafathunnissa, can we proceed to the next slide?
Yes, ma'am.
Okay. So why doing a proper refractive error evaluation is important? Because as I told you, if accommodation system is not relaxed properly, you all know that AC by A ratio exists. That is, there is a very strong relation between accommodation and vergence, right? So anything wrong with the accommodation system is also going to induce problem in vergence system. You can even induce phorias if you have not corrected refractive error properly. Okay. So instead of correcting the binocular vision problem, you're actually creating a binocular vision problem over there. So steps in assessing, there are a lot of tests. Always start with the sensory test first. That is, Worth dot and stereopsis test has to be done first before going on to the Motard test. Okay. And you have a lot of tests in binocular vision exams. Always never forget to, skip direct test. For example, for your accommodation, your direct test is your accommodative amplitude, right? Or monocular accommodative facility also gives you a lot of values. Check for the accommodative amplitude. For vergence, you need to check. You cannot skip fusional ranges value. You cannot skip the smooth vergence or the step vergence values. Otherwise, if you miss direct test, there will be problems with the diagnosis, because in diagnosis, you always see for direct test. Indirect tests are thus just supporting your diagnosis with the direct test values. For example, your monocular accommodative facility and binocular accommodative facility. Remember, accommodative amplitude test and accommodative facility test both has to be done monocularly as well as binocularly, both. It should not be done only monocularly, because monocularly when it's done, it gives you insight about the accommodative problem. Binocularly when it is done, it gives you insight about the vergence problem. That is, if a patient has issues with the monocular accommodative amplitude and facility values, and if binocular values are good, it means there is a problem with the accommodation system. And if monocular values are good, but binocular values are a problem, then it means then there are issues with the vergence system or the interaction between accommodation and vergence. So never ever skip direct test. Cover test, it's a very simple test. We all do, we all know. But in cover test, still I have seen many people who do cover test only with the light source, even for near. If you don't give a accommodative target, if you don't control accommodation over there, then automatically you are going to underestimate or overestimate the phoria or tropia, right? So you need to give proper accommodative target over there. So that is very important. Okay. Rafathunnissa, go to your sensory test slide. Because as I told you, whenever you do any binocular vision evaluation, start with the sensory test first, and then you come to the motor evaluation. Go to the Worth and stereopsis slide. Okay. So Worth and stereopsis, usually we all do Worth only for one distance and with lights on, right? But ideally, if you really need to understand this, especially helps with amblyopes and strabismics. If you want to do Worth properly, then do it for both distance and near, lights on as well as lights off. Because lights doing it for good distance and near will tell you what is the size, roughly the size of the suppression scotoma. If the suppression scotoma is small or big. If at distance a person is suppressing, okay, and if near also there is suppression, it means the suppression scotoma is very big. Okay. Now, lights on and lights off. Remember, if the person has suppression with lights on and with lights off, there is no suppression. It means it is a very superficial suppression. But if there is suppression in both lights on and lights off, it means the suppression is very deep. The amblyopia is very deep over there. Because lights off is an artificial viewing condition in which your brain has not adapted any suppression or any such adaptive processes. So even in that condition, if the patient suppresses, it means the suppression is deep. So take home for word for dot, do it for both distance and near. In fact, you can do it for any distance to check where fusion is. Do with lights on and lights off. This will give you a lot of insights. Okay. Then stereopsis, you would have seen both the type of stereopsis, titmus as well as randot, right? Titmus has a lot of monocular cues, but your randot stereo test doesn't have much monocular cues. So you actually need to understand properly whether the sensory system is working proper or not. The randot test is really good, but the titmus test also can be done. But mention which booklet you used for testing stereopsis, because that tells you whether you tested for the local stereopsis or the global stereopsis. So stereo test, you mention which one you're using. Okay. Remember, all the binocular vision evaluation is done with the glasses, with the correction, right? And word for dot, we do with lights on, lights off, both distance and near. Okay. Sensory test first, and then comes your motor test. Now, going back to the motor test, going back to the cover test slide. So you do the cover test, okay, and then you do for check for NPCs. Then you check NPA, that is near point of amplitude of accommodation. So you do monocularly as well as binocularly. Now let's start with NPC. NPC, the previously, remember, still people do look at my finger or look at my pen. That is a wrong procedure. Okay. Always either use a target with accommodative demand, that is with some letters or with some pictures where a person has to accommodate. Okay. And or use red green filter or use just a red filter and a torchlight. These techniques are the standard techniques which are used now. Okay. Either use with an accommodative target, you can give an innate target, or use a torchlight with a pen light, pen torch with a red filter or a red green filter. Okay. There are two ways of checking it, subjective as well as objective. Okay. Subjective is based on patient's response. Objective is based on your observation as to where there is a break in the version system, right? So two techniques with the accommodative target, and then either a pen torch with a red filter or a red green filter. One more thing, NPC, whenever you check NPC, okay, always note the break point as well as the recovery point. That is important. For example, you started seeing a patient, you started doing NPC, okay, you give an accommodative target, you move it closer, and there is a break at, for example, at 10 centimeter, okay, and there is a recovery at 8 centimeter itself. That is still good, but you take back and the recovery, the image is getting single and clear only after 2 centimeters. Then the recovery point is very poor. It tells you, it helps you to understand how bad is the problem with the convergence, right? Also do repeated testing, because sometimes what happens, that is, when you test, initially you get values of around somewhere around 8 centimeter or 10 centimeter. Example, say on repeated testing, it receded up to 20 centimeter. So it means that when the patient started reading, symptoms were not there, the patient was comfortable, but down the time, there was an issue with sustaining the near vision performance. So always do repeated testing, at least do it 3 times and see whether there is a receding value is being noted or not. So that is with NPC. Now coming to NPA, NPA you have three methods. One NPA basically you do it monocularly as well as binocularly. You check for the accommodative amplitude, and how do you know whether the whatever you have checked is normal with the patient's age or not? Because we all know that accommodative amplitude varies with age. We use Hofstadter's formula, minimum formula 15 minus 0.25 into age. Okay, previously the medium or average values were used, but now we use, based on the literature, the minimum 15 minus 0.25 into age. You put your values there. I mean, you get the normal values and then you compare with the values which you got. So you can use three techniques there. Push-up technique, pull-away technique, and a minus lens to blur technique. Push-up and pull-away are very simple. Push-up, you give the target, accommodative target to the patient. You push it slowly close and ask for something called sustained blur. This is very important. That is a point where even after trying, the print doesn't get clear. That means the end point of accommodation. You should not note the first blur, but you should note the sustained blur. Okay. That is when a patient says it's not clear, you tell them, try to make it clear. He will tell, yeah, now it's clear. Push it even more. So there'll be a point where he will say, he or she, that now even after trying, it's not getting clear. So that is your sustained blur point. Use that. So this is push-up method. Pull away is nothing. Keep it close and slowly pull away. See when the person is able to read. Pull away technique is especially useful for kids, pediatric population, because it's very difficult to explain to them blur, the concept of blur or the concept of sustained blur. But it's easy for you to note that you're keeping it close, slowly you pull away. The moment the child reads, you understand that that is the point you have to note down, right? So push-up technique works good for adults. Pull-away technique works good in pediatric population. Always remember, amplitudes check monocularly, also binocularly. Okay. If binocular amplitudes are reduced, it means there is an issue with your Virgin system too. Okay. Then for accommodation, you do accommodative facility. You use flippers where you have two plus lenses and two minus lenses on the either side. Always mention what is the power of the flippers that you used. Okay. That you decide based on the accommodative amplitude. And for binocular accommodative facility, you can use your NRA, PRA values. So always mention what is the lens power which you have used in the flippers. Okay. Usually we do with the plus or minus 2 flippers, but it depends. If the patient is not able to clear, we also try with a lesser flipper to actually see the facility or to actually see the dynamics of the accommodative system. So this is also done monocularly as well as binocularly. Start with the plus side. We always do relaxing techniques first. We always start with NRA first, that is negative relative accommodation. You put plus lenses and then you go on to PRA. Similarly, we always check convergence first and then you go on to divergence. Divergence first and then you go on to convergence. So we follow this. So similarly, in facility also, you start with the plus side first and then you go on with the minus side. That is the relaxing accommodation side first and then inducing accommodation side. So do it for 5 minutes, check how many cycles the person is able to complete and record it individually, monocularly as well as binocularly. Make sure you keep it at 40 centimeter. Accommodative amplitude, the distance is varying, but facility, the target distance is kept constant at 40 centimeter and then you do it, right? And then your NRA, PRA. NRA, PRA helps you in a lot of places. If the patient is beyond, in the presbyopic age, it also helps you to understand how much of ad has to be given. And also in binocular vision problems, it helps you to understand how much of ad has to be given. NRA, PRA also tells you how much, whether you have corrected the refractive error properly or not. For example, your NRA value at 40 centimeter, maximum it can be plus 2.5, right? But if it's going more than that, So just imagine, just understand that your refractive correction is not proper. The patient is using excess of accommodation over there. Okay. So it also gives you an insight in that. NRA PRA is a test which is done only binocularly. It tells you the relation between the accommodation and vergence. So it is done only binocularly. It is not done monocularly. Please remember that NRA PRA is done only binocularly. They are supportive tests. They are indirect tests for both accommodation as well as vergence. I hope you remember that I told you, mentioned, please always do direct test. Even if you are skipping indirect test, don't skip direct tests at all. They are very important, right? MEM retinoscopy, we have already discussed how it helps you in understanding the refractive error, in understanding the accommodative system, right? So MEM retinoscopy, make it a must to do in all clinics, even though if you're not doing a binocular vision evaluation. That will actually help you out. Okay. Rafathunnissa, next slide, please. Yeah, next. Okay. Okay. Before that, normative data you should know. Okay. The range, you can take a printout of that and stick it in your binocular vision clinics. Before that, an important one, whenever you do foria evaluation, okay, do it for both distance and near. You can use a modified Torrington test and a Maddox plot. Never forget to do AC by A calculation. How will you do? There are two techniques, calculation method and gradient method. The one which I regularly use is gradient method. Gradient method is very simple. Okay. You check for the normal foria, the regular foria at distance and near. And for near, you put a -1. Once you put a -1, what is going to happen? You're going to induce accommodation over there, right? You put a -1 and again check the foria with the -1. So that the difference will tell you, give you the AC by A ratio. For example, without -1, you recorded around 3 prisms of esophoria. Okay. But with -1, you recorded somewhere around 8 prisms of esophoria. It means for -1, for 1 diopter of lens, the patient exerted almost 8 minus 3 becomes your 5 degrees of foria, right? That much of convergence. So the difference between the two values will give you AC by A ratio, right? So this is a very easy technique, gradient method, to do AC by A calculation. Use that. I think that is not included in the slide. It's a very important technique. You can read upon it. It's a very simple one. Just put a -1, check the foria, and now calculate foria with -1, without -1. The difference between the two will give you AC by A ratio. And once you calculate this, it's easy to classify the binocular vision problem, right? Because low AC by A ratio can easily tell you that it could be convergence insufficiency or divergence insufficiency. Normal AC by A ratio, basic esophoria, basic exophoria. And if the AC by A ratio is going to be high, it will be either divergence excess or convergence excess. Remember, all insufficiencies are going to have low AC by A ratio. Excess are going to have high AC by A ratio. It's very simple. So don't skip gradient AC by A calculation method. It's a very easy technique, very effective technique, and it's a very quick technique, right? You can do it. Go back to the test one by one. We'll see what all is being skipped. So I have told you COVD, quality of life questionnaire, then sensory test, Word dot and stereo, Word dot both distance and near, both with lights on and off, cover test with an accommodative target, both for distance and near, direct measures and indirect measures, NPC with accommodative target or with pen light and your red-green filters or red filters, NPA, the 3 different techniques, then accommodative facility, okay, NRA, PRA we discussed, MEM we discussed. Now fusional ranges. Fusional ranges, you can either use prism bars, or there are a lot of softwares also which are available where you can easily calculate the fusional basin values for distance as well as for near, right? But prism bars are very easy techniques, not much of time consuming, very easy and quickly you can do. In that, whenever you're going to do basin for distance, remember you are not going to get a blur value. There is going to be only break and recovery value. If you get a blur value for distance with basin, then it indicates that the patient's accommodative system is not relaxed properly for distance. Means the refractive error which has been corrected is not properly corrected and the patient requires change in glasses. So remember that is very important. And then you do fusional Virgin's facility. You use flippers, Virgin's flippers, right? Start with the basin first and then the base out. That tells you the dynamics of the Virgin system. So that is also important. Okay. So now just go back to the classification. Okay. Before going to the classification, remember, whenever you assess for phoria, okay, 3 prisms or 4 prisms of exophoria for distance and 2 prisms, for near, it's a very normal 1 plus or minus 2 values. If you see esophoria, that is abnormal. Okay. Any kind of esophoria is abnormal, which is going to induce a lot of problems. So these are very small tips and tricks which will help you to understand what is the condition of the patient that you are examining. Okay. So this we saw based on the AC by A ratio. And accommodative disorders, very quick tip. Okay. Accommodative insufficiency, ill-sustained accommodation, accommodative excess, and accommodative facility. Okay. Accommodative insufficiency, your amplitude of accommodation value is going to be less. Ill-sustained accommodation, your accommodative amplitude value may not be less. Okay. And accommodative insufficiency as well as ill-sustained accommodation, you are going to get a lag in the MEM technique. That is more plus than plus 0.75. It means the accommodative system has an issue over there. That's why you're getting a lag in the MEM retinoscopy values. Accommodative excess is very simple. The moment you get lead in your retinoscopy value, that MEM retinoscopy value, if it goes less than plus 0.5, always remember it could be accommodative excess. Accommodative facility, where your amplitudes will be good and your MEM will be good, but the monocular accommodative flippers value will be less. The facility value will be less. So typical complaint would be from looking to distance and near. When I switch my fixation, there is an issue. This is a typical complaint in accommodative facility. Accommodative insufficiency, typical complaint, not clear. Ill-sustained accommodation, it's clear initially, but slowly after some time, it gets blurred. Accommodative excess, your distance also will get affected, your near also will get affected. It can induce pseudomyopia, right? Okay, then go to the other slides. You have any more slides here? Okay, so you analyze the values, okay? Use these tables, but a very simple technique. Check for AC by A ratios. Check for the phoria, okay? If you see esophoria, if ESO is more for near than for distance, suspect convergence excess over there, okay? And if you see exophoria usually, and if it's more for distance than for near, always suspect divergence excess over there. Again, it is based on AC by A ratio. As I told you, AC by A ratio, your gradient method to check phoria is very important. That will solve half of your diagnosis in non-strabismic binocular vision disorders. Okay, then I'm not going into details of this. Okay. So take home message. So what was the take home message? Correct your refractive error. That's why this session is on basic evaluation. What is a very basic? Refractive error, binocular balancing, proper binocular balancing, right? Proper dispensing of glasses, okay? And any kind of anisometropia, if you see, Okay, if it's more than 2 or 3 diopters, even, even lesser than that, if a patient is willing to go in for contact lenses, advise them for contact lenses. That is going to definitely reduce the difference in the image size. So that is going to help, right? So advice for contact lenses, and then check for accommodative system, very important, because your refractive error is the first foundation and the second foundation is your accommodative system. If there is an issue with the accommodative system, automatically that is going to induce phoria, that is going to affect your convergence values, divergence values, all your fusional ranges values, fusional ranges facility, everything is going to get affected. So first foundation was refractive error, second foundation was your accommodative problems, and then comes your vergence problems, which is actually because of the interaction between the accommodation and the vergence system, right? So these are the important ones. And then the take home was in sensory test first, followed by motor test, relaxation test first, followed by contraction test. I mean, the test wherever you use plus has to be done first, and then with the minus. That's why NRA will be done first, and then there will be PRA, which has to be done. So word for dot, both distance and near, lights on and off. Then you have your stereopsis, NPC. Remember, NPC both subjective and objective, both blur and recovery, break and recovery. And then repeated testing has to be done. Don't just use a light, or don't just use your pen, your finger or whatever. Don't use these techniques. NPA, both monocular and binocular. Use Hofstadter's formula, the minimum one. And then facility, both monocular and binocular. MEM retinoscopy, which has to be done regularly. Then your fusional ranges. Then vergence facility. These are the battery of tests. If this is done properly, and don't forget, very important, gradient AC by A method, your assessment for phoria for both distance and near. And then for near, you again put a -1 and see the phoria status, and hence calculate AC by A ratio.
Thank you
Any
so much, ma'am.
questions we have?
Yeah, just a minute, ma'am. Before the question, I'll complete the quiz answers. Then we'll just see about one case example of whatever you explained us, ma'am.
Yes.
So we have asked questions, 3 questions in the forum. One is, does squint get associated with NSBVA? But as name suggests, it is a non-strabismic binocular vision anomaly where your squint will not be getting associated in this. Major cases, you will not see any squint. If there is squint also, it will not be a non-strabismic binocular vision anomalies. Next, quiz number 2, methods of assessing NPA. As ma'am said, we have 3 methods. One is push-up or pull-away method and minus lenses method. We'll use Hofstadter's formula to calculate the normative data. With respect to that, we'll be calculating whether the amplitude of accommodation is low or high. The last one is the normative ranges for stereopsis. Nothing but this short brush up, 20 to 40 seconds arc will be the normative data for stereopsis. So the case example, whatever ma'am explained, we'll just see with a quick example. One is a 20 years old college student come to us with a complaint of blurry vision and discomfort around his eyes after few minutes of reading. And when you check, the vision is actually 6.6 and N6, both for distance and near. Other parameters are listed here where your NPC is actually normal. And the cover test, anything exo, we have a limits to measure, or 1 diopter exo for distance is normal, 3 diopter exo for near is normal. When it comes to ESO, it is an abnormal one. So we see ESO for near. Then the subjective findings are plano. When coming to your basin and base out prisms for distance, we see there is no blur indicated for base out prism at distance. That is your PFE, there is no blur for distance. And then your vergence facility, we see the vergence facility is actually normal. When we consider the standard deviation, it is actually the normal one. Then getting again into the basin and base out prisms for near. Near is okay, almost with the standard deviation of 2 to 6 prisms or 8 prisms. The deviation for basin and base out prisms are okay. Coming back to NRA, the normative data is plus 2.5 and it is actually correlating with the normative data. PRA, we see low PRA. It is supposed to be -2, but it is very less. And the amplitude of accommodation with respect to Hofstadter's formula, If the age is 20, we take an average of the year's formula 18.5 minus 0.3 into 20, which is 18.5 minus 6. So that should be 12.5 or around. Plus or minus 2 diopters can be excluded, whereas here it is only 5. So amplitude is reduced very drastically. Then the key findings here is your monocular and your binocular accommodative facility is being affected. When both are getting affected, it is not an Virgin's problem. Because if it is a Virgin's problem, your accommodation monocularly will be normal, only the binocular things will be failed. When it comes to accommodation, you see the monocular parameter and the binocular parameter to get affected, or it fails in both monocular and binocular parameters. And in MEM, it is plus 1.25, which is high. High indicates your lag of MEM. So as per the data in the table, we see we'll take the key findings at the first place, monocular and binocular accommodative facility, followed by the MEM. We see that both fails in -2. When accommodation and your accommodation facility in monocular and binocular fails together, it is a accommodative problem. And we have two conditions similarly, accommodative insufficiency and ill-sustained, along with your high MEM. So out of this, anyone could be a problematic one. Along with that, we see PRA to be low. Both will have low PRA. We also see that your base out for distances low, base out for distance or near will be very low. And with respect to ESO, there is no predictable pattern seen in the accommodative parameter. So all these findings will indicate either it is an accommodative insufficiency or it is sustained. So the complaint is that the patient is coming to us with a reading difficulty. When we concentrate and read for more than 15 minutes, he is having some problem with respect to vision and the discomfort. So it could be mostly of accommodative insufficiency. Your PRA is low, then your NPA is low. Since because your NPA is low, we can conclude it as accommodative insufficiency. Ma'am, would you like to add any point in this?
Can you go? See, as I mentioned, always see for the direct test first. What are the direct tests? See for the base in and base out values. See for the accommodative amplitude values. And then see for the facility values. Your MEM retinoscopy helps you to understand the moment. If you just look at the chart, what are the alarming things which you can see immediately? One is the esophoria for near, right? Remember I told you any esophoria is not normal, it is abnormal. And then what can you see immediately? Esophoria, and then the other one which is clearly seen is your MEM retinoscopy value plus 1.25, and then your accommodative facility value. So if in this chart, based on this chart, with my experience, I would first do a proper refractive error evaluation. First check for the refractive error, because near, it could be the person is trying to exert accommodation, because of which there is convergence which is happening. That is over convergence which is happening, which is inducing the poor esophoria for near. So I would first check for the refractive error, and then I will see with the new refractive error what is the MEM retinoscopy value. And if it's still plus 1.25, then I would try to consider giving AD if it is required, and then along with that some vision therapy.
Thank you so much, ma'am. Yes, Gomati, over to you.
Thank you, Meenakshi. Thank you, ma'am. Let's quickly discuss about the questions that has been asked by our audiences in both Zoom as well as in YouTube, ma'am.
Okay.
So first, let's start to discuss about the questions on YouTube, ma'am. One question is binocular vision anomaly and disorder, binocular vision disorder, the same, or is it different?
Yeah, it is same. Binocular vision anomalies and disorder are same. Anything, any anomaly or any disorder means which is not normal or which is not regular. So anything which is deviated from the normal values or normal, the regular subjects, then definitely it is going to be either an anomaly or a disorder.
The next question on YouTube, list out the important tests that has to be done on a routine examination, because we were stressing on MEM, retinoscopy, so on. So what are in routine examination, eye examination, right, whichever has to be done?
Yes. Routine examination, you do a proper refraction, then a proper monocular subjective refraction using fogging and diochrome. Then you do a binocular balance without fail in a routine examination. Binocular balance, MEM retinoscope, NPC, NPA. This should be more than enough to understand whether the patient is going to have any binocular vision problem or not.
Okay, ma'am. So those are the questions from YouTube. Now, a few questions from Zoom. Can stress cause diplopia? Stress is one of the important words these days, no, ma'am. So can stress cause diplopia?
Yes.
And what's the reason behind it?
It can. Because see, stress, your sympathetic nervous system is actually involved with your stress. And the moment a person falls into a stress level increases, your accommodation, virgins, lot of things starts getting disturbed. So automatically there could be diplopia, but it need not be a very huge diplopia. But yes, on and off, a very small amount of diplopia can happen, because one of my patients I have seen very long back, he was an IT professional. Whenever he used to get stressed, end of the day, he used to tell me that I am seeing everything double and falling on each other end of the day, and it's not happening on the weekend. So then we evaluated, and then I understood, okay, stress, because all the values were normal. So stress, yes, it can cause a lot of problems, and diplopia can also be one among them, but not a regular one.
Okay, ma'am. The next question on Zoom. Myopia or hyperopia, which contributes so much for the binocular vision anomaly?
Anything will contribute, but yes, hyperopia will contribute more, because we are all most worried about myopias, obviously, myopia control and a lot of things, but we don't talk about hyperopia. Neither we are very comfortable in prescribing for hyperopia. You see a minus 0.5, minus 1, you prescribe very easily. You see a plus 0.5, plus 1, you refrain yourself from prescribing that. So based on this, I would say hyperopias will cause more binocular vision problems, uncorrected hyperopes.
And there are overcorrected myopes also in between.
So yeah.
Autoref induced.
Yes, that is a very important point. That's why I said that monocular proper subjective refraction is important using fogging, that is the controlling accommodation technique, and then diochrome. And MEM will tell you whether you have overcorrected myopia or not.
Okay, ma'am. There's another question. If every test seems to be normal, but still the patient is telling that the patient is having diplopia, what can be done? It's very practical questions. So how do you handle those patients, ma'am?
First, you explain to them, and first you understand whether it is overlapping of images or whether it is actually diplopia or not, whether it is monocular or binocular. So a lot of people, if there is any uncorrected astigmatism, they tend to confuse with diplopia. So you close one eye and ask them whether still there is double. If they say it is double, then it means it could be an uncorrected refractive error or any corneal issue. Okay. And when both eyes are open, if they say double, then it's actually diplopia. Then you have a lot of tests. If they say diplopia, you have diplopia charting. Okay. You have a lot of tests in new softwares also which are available. Then you can do the regular diplopia workup. But first, check whether it is monocular or binocular, whether it is with glasses, without glasses.
Sure, ma'am. The next question. Which flipper to use? Which accommodative flipper to use? How do we come to a conclusion whether it is a 1.5 or 2 flipper?
Okay. Check, you do their NRA, PRA values first, right? Okay. So if in NRA, you get around +2, okay, then you can use +2. But if in NRA, you get around +1.5 or +1.75, you cannot use +2 flippers over there. But a lot of tables, I mean, the normative values are calculated with ±2 flippers, but you decide based on the patient's accommodative amplitude as well as the NRA values.
Doubt from me, ma'am. Does it have anything to do with the age? The flippers?
Yes, obviously, because amplitude is going to vary with the age, right?
Okay. Yes, ma'am. So those are the questions on both YouTube as well as the Zoom. Thank you so much for your patience, ma'am. You literally sounded like an encyclopedia. Thank you so much for joining today, ma'am.
Thank you. Thank you for the opportunity, and thank you for, I mean, it really felt good interacting with everyone. It's a very good initiative, because usually people call as a speaker everywhere. And here, others are given opportunity to speak, and you're given opportunity to add up points. It's a very good initiative. So I congratulate the whole Agarwal team, especially Maheshwari ma'am,
for this initiative.
Yeah.
Thank you so much and all the best for the upcoming series.
Thank you
Yeah,
so much, ma'am. I'm so
Nivedha,
glad
I
that you
would-
have been part today.
I would like to thank that you. I'm happy that you stress the importance on refraction, and you said the proper history taking and refraction. It's really a take home message for all of us. No, we normally underestimate the importance of doing a proper refraction, and most of the problems are because of improper refraction and undercorrected, overcorrected refractions, and when you do a proper fogging, half of the problems are done. So very and it was very clear, very crisp, and for anyone who doesn't know binocular vision, it was very basic. Your language was very simple, and anybody could understand. And it's going to be in YouTube, and anybody can anytime open it, and then as she said, it's like encyclopedias, and open it and then see and. Brush your basics kind of thing. So it was very simple, crisp, clear, and easily understandable. Thank you so much, Nivedha. So we are looking for another opportunity to connect with you in any of our sessions again. So thank you so much, Gomudi. Shall we close? Yeah.
Yes, ma'am. So thank you so much, Mahimam. Thank you so much, Nivedha, ma'am.
Thank you, ma'am. Thank you. Thank you.
I request all our audiences to post any questions if you have during watching the session. Please post it in the comment box. We will get back to you with the answers. I request you all to kindly follow our Instagram and Facebook page so that you get to know all the updates that is happening at Dr. Agarwal's Institute of Optometry. If you like this video, please give a thumbs up and please share it with your friends. Thank you all so much. Meet you all in the next episode. Bye bye.
Thank you. Bye bye.
Thank you, ma'am.